Hello and good evening. My name is Faris Hussain and I'm one of the Medics Academy and FDocs team members. Tonight, I am introducing our speciality webinar speaker, Dr. Adarsh Shetty. Dr. Shetty is a consultant rehabilitation psychiatrist working in South Wales and is the faculty lead for psychiatry at one of the main hospitals in South Wales. This evening, he will be delivering a talk on the Mental Health Act and what you need to know. This is a vitally important topic for any foundation year and junior doctor. Please, as always, post any questions that you have in the dedicated FDocs Slack channel. I will now hand over to Dr. Shetty.
Hi there, I'm Adarsh Shetty. I'm a consultant rehabilitation psychiatrist. This talk is about the Mental Health Act. I've called it the Mental Health Act, What You Need to Know, because I really wanted to keep it quite basic. What you as a foundation doctor need to know about the Mental Health Act, particularly as a foundation year 2 doctor, and I'll explain the difference between the F1s and the F2s when I go through the talk. So the first very basic thing that we need to know, I'll talk about in the next slide. So the basic thing to know about when to apply the Mental Health Act is that the Mental Health Act is for treatment of a mental disorder. Everything else, including treatment of a physical disorder, is covered under the Mental Capacity Act. This is something really basic, but it's really, really important to remember this as a principle when deciding whether to use the Mental Health Act or not. So when I talk about everything else, including treatment of a physical disorder, is covered by a Mental Capacity Act, we can think back to a real case, actually, which set the case law around this. So if you have a patient with schizophrenia who is psychotic and unwell and is refusing their depot antipsychotic medication, but also has diabetes, and because of the diabetes, which is uncontrolled, their toe has become gangrenous and needs amputation, according to the surgeons can sometimes ring us and say, do you think they have capacity to consent to the operation, the amputation? Or they may say, can he please be detained, sectioned to receive the amputation? And really the answer to that is that the ability to decide whether the patient has capacity to consent to the surgical operation, because the procedure is proposed by the surgical doctors, it would be they who are best placed to assess capacity for that. You could certainly, as a psychiatric doctor or a foundation doctor working in psychiatry, help them and support the process by checking what their mental state is and whether they have any psychotic symptoms, for example, or depressive symptoms that are interfering with that capacity. But you could not make a decision as to whether they do or do not have capacity to receive that amputation. Similarly, with regards to being detained under the Mental Health Act, we would go back to this slide and this principle. The Mental Health Act is for treatment of a mental disorder. So really, under the Mental Health Act, the patient could be detained if the criteria were met to receive, for example, the depot antipsychotic treatment against their wishes for their schizophrenia, but they could not be detained under the Mental Health Act to receive the surgical operation for amputation of their toe, because that is as a consequence of the diabetes, the physical disorder. And doing that would be under the Mental Capacity Act if the patient lacks capacity to consent to the operation, and if it is considered from the surgical team that it is in their best interest to receive that surgery for the gangrenous toe. So essentially, it's really, really important to come back to these principles whenever you feel a bit stuck. Sometimes, of course, things are not that clear-cut in clinical practice. Delirium, for example, is a disorder that spans both. Is it a mental disorder? Is it a physical disorder because of an organic condition? And what I would say for things like that is always please seek advice. You're rarely going to be on your own. You will always have somebody on call with you or your consultant supervisor or senior trainee, and you will always be able to ask for advice if you're unsure. But as something basic in your own mind, please keep these principles in mind. So Mental Health Act is for treatment of a mental disorder, and everything else, including treatment of a physical disorder, is covered by the Mental Capacity Act. Obviously, if a patient has capacity, and they did go and have an operation against their will, or any procedure done against their will when they have capacity to consent to it, that would be considered assault or battery, really. And this case of a patient with schizophrenia is actually a real case, and it did actually set case law for the future. And in that case, the courts decided that the patient, although they had schizophrenia, although they had ongoing psychotic symptoms and delusional beliefs, that they did actually have capacity to make a decision about that surgery, and they did not have the operation as a consequence because they were not willing to have it. So the Mental Health Act that we are referring to is the Mental Health Act 1983, which was amended in 2007. And I've just put some of these terms up so you will get familiar with them. These are terms you will hear when you're working in mental health and psychiatry. So the old terms that we would have heard have been things like RMO, or Responsible Medical Officer, and ASW, which is Approved Social Worker. The new terms now that have replaced those are AC, Approved Clinician, RC, Responsible Clinician, and AMHP, often abbreviated as AMP, so the Approved Mental Health Professional. So years ago, before the amendments to the Mental Health Act were introduced, I would be the consultant psychiatrist and the RMO for a patient who was detained. To detain a patient on a longer term treatment or assessment section, it would need, and still does, 2 doctors and usually a social worker with special qualifications called an ASW. What has happened in the new amendments on the right-hand side is that that social worker role has been expanded to other professions. So you can now have a nurse, for example, who has undergone further training, the AMHP or AMP training, and they can then be warranted to work as an AMHP, and they can, in combination with 2 doctors, detain a patient under the Mental Health Act. Similarly, the role that used to be done by the RMO, doctors, psychiatrists, before, has now been expanded and can include other professionals, for example, psychologists or nurses, as long as they continue and do that special qualification called an AC or Approved Clinician Qualification. Having said that, the majority of approved clinicians and responsible clinicians, the responsible clinician being an AC who is in overall charge of the patient's mental health care, the majority of these ACs and RCs are doctors and consultant psychiatrists or senior psychiatrists such as specialty doctors and associate specialists with the AC qualification. So basically, you would be hearing terms like RC, AC, etc. when you're working in mental health, and you'd hear things like, where's the AMP? Is the AMP going to assess the patient? That's what it stands for, the Approved Mental Health Professional and the Responsible Clinician. So when we're thinking about the Mental Health Act, these are the simple questions we have to ask, basically. The criteria for detention, are they met or not? And the questions that we would be asking are, do they have a mental disorder? Are there sufficient risks to justify detention? So 2 simple questions, and these generally are applicable across the sections of the Mental Health Act, including the section particularly that is relevant to all of you as Foundation Year 2 doctors. Do they have a mental disorder? Are there sufficient risks to justify detention? So the first question is, do they have a mental disorder? We would ask, what is a mental disorder? And essentially, it's defined in the Mental Health Act as any disorder or disability of the mind, which, as you can see, is quite a broad definition. Essentially, it would be any disorder under the ICD-10 and now ICD-11 criteria, any diagnoses, essentially. So it could be from that list, affective disorders, severe depression, recurrent depressive disorder, mania, bipolar disorder. It could be any of the psychotic disorders such as schizophrenia or delusional disorder. It could then also be things like personality disorders. And these numbers 3 and 4 can be quite controversial and people can be unsure about them. You may actually even go on towards and hear people say, well, this patient has a borderline personality disorder. This is all behavioral. There's nothing that can be done. We can't stop them from leaving hospital because they're not detainable. It's a personality disorder. We can't do anything. And the answer to that actually would be that legally, it is a disorder under the ICD-10, and it can be used if appropriate. The Mental Health Act can be used to detain the patient. Whether it is clinically in the best interest of the patient to use the Mental Health Act is a matter for that patient's consultant and the multidisciplinary team to decide. But just by virtue of the fact that they have an emotionally unstable personality disorder, borderline type, does not mean that you cannot use the Mental Health Act to detain them. Okay. So personality disorders are definitely mental disorders as characterized within the ICD-10. And similarly, the substance use is also something worth thinking about. If you have a patient who has presented on the ward, they're an inpatient and they have potentially used something like cannabis or amphetamines, and they are quite psychotic in front of you. So the diagnosis potentially could be drug-induced psychosis. As long as the criteria for the Mental Health Act are met in terms of risks, then you could still use the section of the Mental Health Act to stop them from leaving hospital. So the fact that the drugs are the cause of the psychosis does not stop the Mental Health Act from being used. You can detain them. Similarly, if you see somebody who has gone off the ward and come back and is now asking to leave, it's clear that they have drunk some alcohol, but they are also showing symptoms of depression alongside it: limited eye contact, downcast gaze, slow speech, ambivalence about whether they want to live or not, anhedonia, and some other symptoms. Then you could potentially use the Mental Health Act, if the risks criteria are met, to stop them from leaving the ward. Just the fact that somebody has alcohol on board does not mean you cannot use the Mental Health Act. So rather than using a double negative, basically you can use the Mental Health Act for any of these categories of patients. What you cannot use the Mental Health Act for is if the problem is solely of alcohol dependence. So for example, you could not detain or section somebody under the Mental Health Act for them to receive acamprosate, for example, or Antibuse. That is not allowed because the disorder there is alcohol dependence syndrome, and you cannot detain a patient under the Mental Health Act to treat that disorder. These list of things, of course, are just examples of disorders. Any diagnosis under the ICD-10 will classify itself as a mental disorder for purposes of the use of the Mental Health Act. Okay, so just to summarize, this slide is the answer to the question, do they have a mental disorder or not? Any disorder or disability of the mind. Remember that they don't have to have a confirmed diagnosis. If there is the possibility that they're suffering from a mental disorder, as long as the second criteria is met around the risks, you can still use a section of the Mental Health Act. So this is the second bit. So the second question we ask is, are the risks sufficient to justify detention? And the risks, when you think about doing a risk assessment, would include risks to their own health, their own safety, and to others' safety as a broad categories. So risks to own health would be about their mental health deteriorating. So if not under the Mental Health Act, is it likely the patient will continue to engage with treatment, take their own medications, etc.? If they don't, what are the consequences? Would their mental health deteriorate? Would their psychotic or depressive symptoms or emotional instability become worse? If yes, then there is a risk to their own health. That's what that particular aspect is referring to. To own safety, of course, refers to not just the obvious risks of somebody saying to you, I am going to go and kill myself. So that category of patients who say that, of course, there's an obvious risk to themselves in that there's a risk of self-harm, if there's a risk of death from their actions. But we must not forget to think about risks beyond that, risks of self-neglect, for example, risks of vulnerability, risks of exploitation, either financially or sexually, in that patient's context. An example might be somebody with schizophrenia who does not believe they are who they are. They believe they're related to royalty and absolutely have lots and lots of money. They believe their name is not what their name is actually saying on their driving license, on their bank cards. And so they cut up all these documents, the driving license, the bank cards, which then stops them from having any money as a consequence of their delusional beliefs, as a consequence of having schizophrenia. We would have to include that risk in our risk assessment because clearly without any money, they're at risk of self-neglect, of not eating food and potentially dying. So those sort of risks which are not completely obvious also need to be included. You may also want to think about the risks of retaliation from members of the public. So if there's somebody with schizophrenia again who has continuing auditory hallucinations, voices of people saying nasty things to him and saying things like you're a pedophile, and if their reaction to that is to shout out loudly, irrespective of the environment they're in, that they're not a pedophile, you can imagine if they were to do that in public, what the response of the public would be if they're constantly shouting out things like that about not being a pedophile, etc. So the risk of retaliation from members of the public, people around them because of their behavior would also need to be considered when you're thinking about risks to own safety. And similarly, when we're thinking about others' safety, the obvious risk is if somebody is saying to you, I am going to go and harm such and such a person, or I am going to go and kill such and such a person. But you would also have to think of beyond that risks to objects, risks to property, risks to children, risks to animals potentially, just the wider environment around them. Are other people at risk in some form or the other? Is there a risk of verbal aggression? Is there a risk of physical aggression? So all of those things would, to summarize, encompass the risk assessment, which would then be the answer to the second question. Are the risks sufficient to justify detention, to stop them from leaving hospital? So I'll touch on these holding orders and I'll mention two of them which are really important. The second one, the section 5.2, is the one that's particularly important to you all, to the F2s in the audience. So, a section 5.4. This is done by a qualified nurse. The patient does have to be an inpatient. Now, they could be an inpatient on the mental health ward, but the section 5.4 is implemented by the nurse, not the doctor. It lasts for 6 hours. And really, that 6 hours is a holding power to allow the doctor to get there to make a decision about either a longer holding power or whether an assessment or treatment section is necessary. So a qualified nurse does a section 5.4. The patient has to be an inpatient, so it cannot be done in A&E, cannot be done in outpatients, and it lasts for 6 hours. Although it lasts for 6 hours, it would not really be acceptable if a nurse has rung you to say, doctor, we've stopped this patient from going there on a section 5.4. We'd appreciate it if you could come and assess this patient, please. It is not acceptable to say, well, it lasts for 6 hours, so I'm going to come there at 5 hours and 30 minutes. Because in terms of priority, somebody wanting to leave the hospital and being placed on a section of any sort is quite high on the list of priorities. Obviously, if you've got somebody medically unwell in front of you or collapsed, then that person would take priority. But apart from those scenarios, something like a section 5.4 would be quite high up in your list of priorities to be able to go and attend to that call. And the section 5.2 is the most important section that is particularly relevant to yourselves as foundation doctors. And it can be done only by foundation year 2 doctors, not F1 doctors. So section 5.2 is done by the doctor or approved clinician in charge of the patient's treatment, which you as foundation doctors would not be, but you would be their nominated deputy. And because the nominated deputy, you will see on the section paperwork, has to be a registered medical practitioner, it would not be an F1 doc. But I think this talk would be helpful for F1 docs anyway, because you'd be moving on to F2. And the moment you become an F2 doctor, foundation year 2, you would be able to sign the Section 5.2 forms. Once again, a Section 5.2 the patient has to be an inpatient, so cannot be done in A&E, and it cannot be done if you see somebody in clinic who you think is manic, is about to drive off and clearly at risk to themselves and others, you would not be able to stop them from leaving a clinic by using a Section 5.2. The only thing that could be done, you'd have to seek advice from your supervisor, obviously, is to organize a mental health act assessment for them. And after discussion with the supervisor, if they're really concerned about immediate harm to other people, particularly because of their driving in that specific scenario, then the police could also be contacted. Okay, but all those things would come after you seek advice and supervision around what is best to do. But you certainly cannot do a Section 5.2 if the patient is an outpatient or is an A&E. In terms of being an inpatient, if the patient has come onto the ward and has been clerked in or some semblance of clerking in, that is what would be considered as being an inpatient. A Section 5.2 lasts for 72 hours. And the 72-hour period may have arisen really to cover the weekend. They cover the patient who comes in on Friday at 3:30 with their usual team not being there and suddenly asking to leave. It lasts for the weekend period. The original idea may well have been to continue till Monday so that their original team, who knows them well, could review them. But practice differs, and certainly the ideal thing would be to keep the Section 5.2s, which are holding orders, to the minimum amount of time. And certainly in the place where I work, trainees are advised and the nurses are advised to contact the on-call consultant and the emergency duty team, so the duty social workers, to decide whether to conduct a mental health act assessment over the weekend or not. And most of the time they do. So even though it can last 72 hours, that's just the maximum it can last. The aim would be to try to get it done, the assessment, the fuller assessment done sooner than that, even if that means it happens over the weekend. So Section 2 is often called an assessment section. But you can treat a patient under a Section 2 as well. So like I said earlier, to detain a patient under Section 2, you would need an approved mental health professional who, as I explained, is usually a social worker with special training, plus 2 doctors. The 2 doctors one of them certainly would need to be what's known as Section 12 approved. So that is what most higher trainees in psychiatry are. They go through special training, they have certain qualifications, and then they become Section 12 approved. And the second doctor, ideally, would be the patient's own GP who knows them well. But often they could be 2 separate doctors. The main thing is that the AMHP and the 2 doctors are independent of each other. And the idea is that 3 independent people getting together make a decision that this patient does need to be detained under the Mental Health Act. So Section 2, although it's an assessment order, you can treat as well. A patient, for example, who comes in quite psychotic, potentially because they've used drugs, may be considered to be having drug-induced psychosis, but after a few days when the drugs have gone out of their system, they're on a Section 2 and they're still displaying psychotic symptoms, and it may be that the diagnosis is not drug-induced psychosis, it's a more chronic psychotic disorder. It does not mean that the patient now needs to be detained on a different section if they're still refusing medication. They can continue to be treated on the Section 2. It lasts for 28 days, so just under a month. The patient does have rights to appeal against their section within that period, and the Section 2 can be discharged either by an independent review tribunal or a manager's hearing, both of which are 2 levels of scrutiny, or by the responsible clinician themselves. They can sign an order and the patient can be discharged. It may be that the patient needs to be continued on a much longer term section, in which case the Section 3 is something which may need to be considered for some patients, particularly if there's a clearer diagnosis and the treatment is fairly clear, then they could be placed on a treatment section. Once again, there would have to be an assessment by an approved mental health professional and 2 doctors, exactly the same as I explained earlier. This tends to be called a treatment order and lasts for much longer. It lasts for 6 months. But again, it does not have to last for 6 months. The patient could be discharged sooner than that by either the tribunal or a manager's hearing, or by the responsible clinician themselves. Also, it's important to emphasize that a patient does not need to go through this entire process of going on a Section 5.2, then a Section 2, then a Section 3. These can all happen independent of each other. So it may be that a patient is seen by the doctors in the community and they consider that this patient is quite unwell. They have a diagnosis from before, the treatment is fairly clear. The AMHP and the two doctors can do a Section 3 straight away. It does not need to be that they have to be on a Section 2 first and then a Section 3. Similarly, even if they do have a diagnosis, but it's considered that this is a newer presentation or an unusual presentation, which is not in keeping with their diagnosis or previous symptoms, the AMHP and Section 2 and the two doctors can decide to do a Section 2 as well. I just wanted to explain that you might hear this term called Section 17 leave sometimes. When a patient is detained under the assessment or the treatment order or any of the forensic sections that I have not mentioned in this talk, any leave both within the hospital grounds and outside the hospital grounds, so out of the ward that they're in, does need to be authorized by the responsible clinician. The forms need to be signed by the responsible clinician. This is not something that you as trainee doctors would be able to sign. It's not legal for you to sign them, so please don't feel pressured if somebody asks you to do that. Those decisions are always made by the responsible clinician. You can certainly help in the decision making by assessing the patient, discussing with your senior, with the responsible clinician, but the actual forms for Section 17 leave are signed by the responsible clinician. I'd also like to mention earlier when we spoke about the Section 5.2s and we said they were holding orders, you may well have the question, can you actually treat a patient on a holding order or a Section 5.2? So a clinical example would be a patient who is on the psychiatric intensive care unit, who is extremely psychotic, very agitated, is starting to throw furniture around because of their levels of agitation, and there's a real risk to themselves and others. So they've been placed on a Section 5.2, which stops them from leaving the ward. But the nursing staff then talk to you and say, look, they're going to need medication. They're just not accepting any oral haloperidol. Can we give them intramuscular haloperidol under the Section 5.2? So I would go back to that first, the second slide that I showed about the principles of the Mental Health Act. The Mental Health Act is for treatment of a mental disorder. And I said everything else, including treatment of a physical disorder, is under the Mental Capacity Act. And really, we would be going back to that principles. The 5.2 is a holding order, so you would not be treating under that. However, you would assess whether the patient has capacity to accept that haloperidol, to accept medication for rapid tranquilization, do they understand the consequences of their behavior, etc. And if they do not have capacity to consent to that medication, then that medication, the intramuscular haloperidol, can be given to them in their best interests to prevent harm to themselves and or others if they lack capacity. And in that sort of scenario, it may well be that the patient lacks capacity to make that decision. But that's the legal framework under which you would be giving the intramuscular haloperidol. You would not be treating the patient under Section 5.2. So this is a really important bit to remember and keep in mind, that the community treatment orders have come into being for the last several years, and they involve a change in your thinking and your actions should you be called about a patient on a CTO. So just to give some background, over the last few years, there are an increasing number of patients on community treatment orders, CTOs, in the community. These CTOs have certain conditions attached to them. They could be, for example, to receive prescribed medications. And if the patients do not meet those conditions or break those conditions, as a last resort, the responsible clinician can recall them into hospital, into the mental health unit. Although that can happen, a patient on a CTO in the community may still choose to come into hospital informally, i.e., they are still on a CTO, but they have decided that actually I'm not feeling too well. I would want to come into hospital for a few days. A bed is arranged and they get admitted to the mental health unit. Having been admitted as an informal patient on a CTO, if they then decide that, oh, I don't want to stay here, I want to go, and there are concerns about their mental health and risks to others, if you get called to see a patient like that, please remember that you cannot use a Section 5.2 to stop them from leaving hospital. You could go back to the principles of the Capacity Act, and if there is an immediate risk of harm to themselves or others, and they lack capacity to make the decision to stay in hospital, the nursing staff could stop them in hospital under the Mental Capacity Act if it's in their best interests. But the only legal way then to stop the patient from leaving the hospital would be through the use of the recall papers. And once again, just like the Section 17 forms, these are not papers that you as trainees could sign. These would have to be signed by the responsible clinician, who's often the consultant psychiatrist. In our trust, in our health board, it is the consultant psychiatrist on call who would do this. So we, in our practice, actually carry recall papers around with us because you never know when you might be asked to sign the recall papers for a patient on the ward. Now, similarly, if you see a patient in the community who is extremely unwell and needs to come into hospital, is refusing, but it turns out they're on a community treatment order, then rather than organize a mental health act assessment with a social worker, AMHP, and 2 doctors, the on-call consultant psychiatrist, the on-call responsible clinician would have to make a decision to recall them into hospital by serving them the papers for CTO recall. If a patient on a CTO who is admitted informally wants to leave, as I say on the slide, you cannot use a Section 5.2. It would actually be unlawful to stop them from leaving hospital using a Section 5.2. The only way to do it legally would be through the recall papers, which would need to be served by the consultant psychiatrist or responsible clinician for that patient. So I said this talk was fairly basic. I don't mean this to be patronizing in any way, but just to understand what do you do when you're called from the mental health ward about a patient who wants to leave. These are the steps you would follow, really. Go to the ward, read the notes, speak to nursing staff, obviously assess the patient as long as it's safe to do so. Try to do it jointly with the nursing staff in a safe manner so that your exits are clear, etc. And if required, you can discuss it with a senior. Never forget that you will have senior support. You can always discuss it. It is not a legal requirement that you speak to a senior when deciding to do a Section 5.2. But if you do want help or advice, you can always ask. Nobody would say, please do not ring the consultant, it's your decision. You can always ask for advice and you can always discuss the case with a senior before deciding to make a decision. I will now show you where the Section 5.2 forms are available for Wales on the website. It is important to say that these are legal forms. I can show you where the forms are available for Wales. And similarly, you would have to find out if you work in England, where you would find these forms. In actual clinical practice, your mental health department will have a mental health administration section, and all the mental health wards will have these forms printed out. It is just as a backup that I can show you on through Google where the forms are available for Welsh patients. So if the patient is an inpatient in a hospital, in a mental health hospital in Wales, then I can show you through Google where to find the correct forms. I'm going to move to Google now. So this is the way to find the correct Section 5.2 forms as a backup if you haven't found them on your hospital wards. But to emphasize, this is the way to find the correct Welsh Section 5.2 forms. In England, the forms that I'm going to show you are not going to be valid or legal, okay? So for the Welsh Section 5.2 forms, you would type in MHA prescribed forms Wales. The first website that comes up, if you click on that, It's the nccu.nhs.wales website. If you go down and click on HO forms, you will see the Welsh section documents here. And the one we are looking for is the section 5.2 form, report on hospital inpatient. So if you click on that, that's the section 5.2 form. I'm going to show you that in a minute filled out. And so it's 2 pages. And as I say, that's what it looks like. Okay. So this is the Welsh section 5.2 form. But most of the time, you should be able to find these forms on the wards that you're working on, or please ask the Mental Health Act Administration Department. They will have plenty of these forms printed out. They tend to be printed out on pink paper most of the time. To my knowledge, they do not have to be printed out on pink paper to be legal, but most of the time when they're on the wards, you will see that these are the pink paper forms. Thank you. I will now move on to showing you a case scenario, after which we'd go through the section 5.2 forms to complete them. Okay, the clinical scenario is this one. So this is an on-call scenario that's quite common. I'll give you a few minutes to read it. So in this scenario, you're faced with a man who is appearing quite psychotic, is displaying psychotic symptoms such as auditory hallucinations and ongoing complex delusional beliefs. There does seem to be evidence of risk both to himself as well as to other people, the people that he believes are part of this conspiracy. And the question would be, would you be considering a section 5.2 for this patient or not? My suggestion would be, having read this scenario, that this is a patient I would definitely be considering a section 5.2 for, because of the reasons I just mentioned. The mental disorder, there does appear to be a mental disorder, and there do seem to be sufficient risks to stop this patient from leaving hospital. So what I'm going to do now is just go through a section 5.2 form and give you an example of how you might fill it out to explain the reasons as to why you are considering a section 5.2. I will move on now to the completed section 5.2 form. This is the form HO12. Again, to emphasize, this is the Welsh section 5.2 form. This form would not be valid in England. You would need an English section 5.2 form, which would be similar in its domains, but would be different in appearance. So this is a Welsh section 5.2 form, and you will see at the sides of each of these boxes, there are some explanatory notes, which will give you some guidance on what to put in those boxes. It's also worth saying that you can write outside the boxes. It is not essential that you squeeze everything into the box. Also, if you can, please write in block letters, because these are legal forms, they do need to be legible. However, if you have a fairly good handwriting and your handwriting is legible, you can write it in running handwriting as well. Obviously, I've typed it here for the purposes of training. You wouldn't be expected to type into these forms. So this is what you would put down. These are the bits here that you would fill out. I've put the name of the hospital that I work in, and I've put in the full address. Please check with your Mental Health Act administration team the correct address of the hospital that you are working in and the hospital that the patient is in. That's the address that you would be putting into that box, including the postcode. Then you would put in your full name here, and you would say, I am. It says delete A or B as appropriate. And clearly, you would not be the registered medical practitioner or approved clinician. So please delete A, as I have done up there. And you are the registered medical practitioner, not approved clinician, who is the nominee of the registered medical practitioner or approved clinician in charge of the treatment of. So you would leave B as it is, perhaps delete the approved clinician bit if you're able to. In charge of the treatment of Joe Bloggs. If the patient has a middle name, please use that middle name as well. And this is the bit that I have put down in the box. You can see that I have written outside the box. As I said, that's okay. This is the bit where you put in the clinical features that justify the detention. And on the left-hand side in the explanatory notes, you can see the full reasons why informal treatment is no longer appropriate must be given. So that's what this box is about. Although I have put something into this box, that is just an example of what you might put in. Please don't use exactly the same words. That's not what I'm saying. I'm just saying these are the areas that you would need to cover when you're completing this particular section of the form. So I've chosen to put in Mr. Bloggs is displaying clear psychotic symptoms, including auditory hallucinations of his flatmates and tutor conspiring against him. And he has delusional beliefs that his flatmates have implanted a device in his head. I've put that to answer that first question. Is there a mental disorder? Is there a possibility of a mental disorder? So I've included the symptoms that are making me think there's a mental disorder there. And then the second bit, of course, is around the risks. So I've put down there are concerns about poor self-care and self-neglect. He is also making threats to harm his flatmates because of his delusional beliefs. Thus, there is a risk of harm both to himself and others. So I've covered the issue of risks as well over there, and you can choose to elaborate much more on that should you wish to. I have then put down that he does not believe he is mentally unwell. He does not want medications. He does not want to stay in hospital, and he wants to discharge himself. And that sort of covers the area about why is informal admission not possible? Why can't this patient stay on as an informal patient? So these are the areas that you would need to cover when you complete the content box in this. The next bit of the form looks like this. You would delete the phrase which does not apply, and most of the time, if you're on call, you would not be putting it in the internal mail system. That's why I've crossed off that first bit. But you would be giving it either to the Mental Health Act administration team yourself by hand, or you would hand it over to the nurse or ward manager of the ward where the patient is on. And so that person is a person authorized by the hospital managers to receive that Section 5.2 form. My advice would always be to make a corresponding entry in the clinical notes of the patient to say that you've completed a Section 5.2, the clinical reasons why you've completed the Section 5.2, and to give the name of the person that you have handed the form over to. Because a lot of the time, areas where I worked, the difficulty is that the Section 5.2 form cannot actually be found the next day, depending on the processes and who it was given to. So it's really important that to tackle that, you name the person that you've given it to, and there's a clear system and process in place to register and record that Section 5.2 form, as well as to get it to the Mental Health Act administration team the next morning if this happened in the night time. Then, of course, on the second page, you would sign your name there and you would put the date as well. And then this bit, once you've handed it to the person authorized to receive it, they would complete this part 2 bit. As I say, please always in the clinical notes, not on the form itself, but on the clinical notes, please record who you gave the form to, the full name of the nurse or the ward manager that you handed the form to. That's always helpful in being able to trace this back. So we've gone through a scenario. I've gone through the Section 5.2 form, and the last slide that I have. So this is the last slide that I have, essentially just talking about what you would put in that content bit of the section 5.2 form. You could put the symptoms like I just showed you. You could put in the diagnosis if the patient already has a diagnosis. Please talk about the risks to self and or others so that it's clear. And remember, it does not have to be an obvious thing like the patient actually saying, I'm going to kill myself. Your risk assessment has to be broader than that to make a judgment as to whether to use the section 5.2 or not. If you can, and if this is right, then you could talk about their lack of insight, the fact that they may not be wanting to take their medications, they may not be wanting to stay informally in hospital, and potentially for completeness, you could add a statement around home treatment is not an option because of the risks. Now, each patient is different, each clinical situation is different, and these are just pointers to you, not specific things that you have to put down on the form. This is just advice on the areas you might want to consider putting in the section 5.2 form, because these are the areas that you would have thought through clinically before arriving at the decision to complete the form. That basically is the end of my talk. I hope it's been useful. Thank you for listening.
Thank you, Dr. Shetty. That was a comprehensive overview of the Mental Health Act and what we as junior doctors all need to know about it. Please do post any questions you have for Dr. Shetty in the dedicated Slack channel. Please look out for our future speciality webinar talks on Facebook and via our other social media platforms, so you can see all the talks delivered by Medics.Academy. You can find more information on our website, www.medics.academy, where you can see what else we offer in terms of courses and resources for foundation year doctors and medical students. As always, thank you very much for tuning in, and I look forward to seeing you next time.